Good morning. My name is Patrick Lynch. I'm a gastroenterologist at the University of Texas MD Anderson Cancer Center in Houston, Texas, USA. For the last 25 or 30 years, I've worked in the field of inherited cancer susceptibility, and I'll be talking today about a condition, hereditary non-polyposis colon cancer, or Lynch syndrome, named after my father, Henry Lynch, which is the most common inherited cancer predisposition involving the colon. About 3% of all colorectal cancers are thought to be due to hereditary non-polyposis colon cancer, or HNPCC. The key features of HNPCC are early onset colon cancer with an average age of about 45 years. The other key feature is endometrial cancer, which occurs in many, many women with HNPCC. There are other extracolonic tumors involving the stomach, small bowel, unusual urinary tract tumors, and occasional skin tumors, sebaceous adenomas and carcinomas that we call the Muir-Torre spectrum of tumors. The key question for clinicians is, how do I identify a potential patient with this condition, and how do I evaluate them? In early years, family history was really the key feature that was relied upon. Family history plus presenting clinical features of early onset colon cancer. That's still a very helpful approach when present, but in the US and Western Europe and in other countries, the approach to evaluation has focused more on the characteristics of the tumor itself. When patients develop a colorectal cancer at any age, there are certain features called microsatellite instability, which is a key clinical, pathologic, molecular hallmark of colon cancer. This microsatellite instability can also be detected by performing relatively simple immunohistochemistry evaluations on the tumors to detect evidence of loss of expression of the proteins that are associated with the genes responsible for this condition. So a pathologist, using very standard techniques, can perform immunohistochemical stains against the proteins that are involved in this condition. When these are present, when these are informative, I should say, it indicates in all likelihood the presence of an underlying HNPCC, and a patient then has a recommendation to go on with mutational testing. Now, to many clinicians, all of this sounds very esoteric, very remote, very difficult to approach. But again, using fairly standard immunohistochemical techniques, key clues can be identified through the simple evaluation of any tumor. And so in the US, in many, many institutions, we will routinely evaluate every colon tumor, or at least every colon tumor under, say, age 70, for evidence of these cardinal features. Again, when these features are informative, a simple recommendation for genetic testing is made. I should emphasize at this point that the genetic testing itself is a readily available clinical test performed in reference laboratories that perform testing for a variety of cancer predispositions, such as those predisposing to hereditary breast ovarian cancer, the so-called BRCA genes. So again, a clinician need not really understand the nuances of how this testing is performed. One can be very comfortable in knowing that the laboratory tests, although very involved molecular techniques involving polymerase chain reaction and sequencing and so forth, although very, very complicated and difficult to understand the details of, are nevertheless routine reference laboratory undertakings that are well validated with reports that are very, very detailed, but in language that is relatively simple for the clinician to understand. So we now have an algorithm, we now have a process for evaluating patients or starting with the tumors from patients, and following in a very simple stepwise process from evaluating tumor to, in informative cases, evaluating the patient for evidence of an underlying germline mutation. So although HNPCC is relatively uncommon, only accounts for about 3% of all colorectal cancers, when a patient is identified to have this, it certainly can affect the management of that particular patient, perhaps the scope of the surgery that's undertaken, a more extensive resection as opposed to a less extensive resection in a patient not carrying this condition, perhaps consideration of hysterectomy and oophorectomy at the time of surgery because of the presence of increased risk of endometrial and ovarian cancer. So management of the individual patient can be optimized. As importantly, and in my opinion, more importantly, once a mutation is identified, we now have a foundation for performing predictive testing in other members of the family. So importantly, rather than simply, and this is important, rather than simply recommending, for example, colonoscopy in siblings and children of a person with early onset colorectal cancer, rather than simply recommending clinical screening, which, as we know from the genetics of this, will commonly be unnecessary because these individuals can be detected to not be carriers of risk by means of predictive testing. When one relies on predictive testing, identify a mutation in one of these genes in a patient with colon cancer, you now have a solid foundation for then testing siblings, children, more remote relatives to see if they have the same mutation. If they do, they're at increased risk and they warrant enhanced surveillance according to well-described stepwise approaches for screening. When otherwise at-risk siblings and children and more remote relatives are tested for the mutation that was found in the original patient with cancer, when these relatives are tested and found not to be a carrier of the mutation, then they can now be regarded as at average risk and do not need the enhanced surveillance that they would otherwise be recommended and be put through. So we have an opportunity for important cost savings and avoidance of risk of potentially unnecessary procedures in these individuals. Yes, it's fairly detailed. Yes, it can be fairly involved, but there are well-accepted stepwise approaches to this. One thing that I would conclude with is it's been my experience in discussing these issues with clinicians in countries in South America. There seems to be, in many cases, capability of doing this work, but perhaps a lack of confidence in the interpretation. Do I really feel confident in my interpretation of the immunohistochemistry? Do I really feel confident in my recommendation for predictive testing? Can I really rely on this? And the answer is, please, clinicians, consult with individuals in your centers of excellence here in Brazil and elsewhere in South America, because there now is a group of clinical investigators who are very, very conversant with these issues, who are members of international consortia that are devoted to these issues. I do believe that with attention to quality assurance and quality improvement in both the laboratory methodology and in the selection of patients for evaluation, we will very soon reach a comfort level with the day-to-day routine management of these patients with inherited cancer susceptibility. Thank you very much.